Hello, ladies and gentlemen. You're welcome to the masteranatomy.info. And you're with Dr. Akan. Today we'll be talking about the anatomy of the leg. So in our objectives, we'll cover the muscles of the leg and their compartments. We'll also look at the blood supply and innervation. Then we'll look at the clinical correlates of damages to these muscles or the blood supply or the nerves. So let's see where the leg is located. The leg is that part that's between the knee and the ankle. All right, the knee and the ankle. Oh, okay, so you can see the knee joint and the ankle. Okay, so it's that part located between that. And it comprises two bones, the tibia and the fibula. All right, so the different parts of this bone has been, I'm sure you must have done some practicals to look at the different parts. And this is the tibial tuberosity where the tendon of the quadriceps femoris would attach. It's also the upper part is where the patellar ligament. So many times the two of them are called one. The tibial tuberosity for the attachment of the patellar ligament or the tendon of quadriceps. Okay, so this is the fibula bone, and that's the neck of the fibula, and that's the head of the fibula. All right, and so you have it. It looks a bit flat. It looks a bit flat like there. And we have the distal end, which has, so you have the lateral malleolus here at distal end, and you also have the part that helps to form the medial malleolus from the tibia. Okay, so these are the condyles. This is the medial condyle, the lateral condyle. Then you also have the medial intercondylar tubercle, and the lateral intercondylar tubercle. So this is the anterior view, and this is the posterior view of the bones that make up the leg. Okay, so let's see different movements of the foot. Okay, so the muscles from the leg will go into the foot to control the movement of the foot. So we have inversion. Okay, so that's a diagram showing inversion and this eversion. Then we also have dorsiflexion and plantar flexion. So I'm going to tell you the muscles that help control this. And the muscles of the anterior compartment of the thigh would help to form dorsiflexion. Those on the posterior compartment of the thigh would help form plantar flexion. All right, so what about eversion, and what about inversion? So we'll look at these things when we talk about the lateral compartment muscles, and also we'll also look at some of them when we talk about the deep posterior compartment muscle and the superficial posterior compartment muscle. So we'll look at them. And this is another form of flexion. Okay, so this is what you call the dorsiflexion. All right, it's also called flexion movement, and this is what you call plantar flexion, also known as the extension movement. Then also this leads us to the toe, and that's the extension of the toe. All right, so that's how you extend the toe, and this is the flexion of the toe. All right, the flexion of the toe taking place there. So with that, let's look at the different compartments of this leg. The leg is divided into three compartments. We have the anterior compartment and the lateral compartment, also the posterior compartment, which is divided into two, superficial and deep. So let's see what makes these compartments, what divides these various compartments. So they are divided by intermuscular septum and also the interosseous membrane. Okay, and so we have the posterior intermuscular septum, we have the anterior intermuscular septum, we have the transverse intermuscular septum, and we also have the interosseous membrane. So this septum would help to band and keep the muscles in different compartments. Okay, and so it also helps to keep the vessels, and there's hemorrhage, so it restricts them to a particular compartment so they don't spread around about. So let's look at the anterior compartment and the muscles. So the anterior compartment of the leg is formed by the muscles anterior to the interosseous membrane. Or in fact, basically, muscle anterior to the interosseous membrane will form the anterior muscles, anterior compartment of the leg. Those on the posterior part of this interosseous membrane. I hope you know the interosseous membrane is that membrane that links the femur and the tibia. All right, it just takes proximally distally, so proximal distally. Okay, So that's the interosseous membrane. So the muscles anterior to it will form the posterior compartment. So the posterior form posterior compartment. You're going to wonder where is lateral compartment coming from. I'll show you that in just a moment. So the anterior compartment muscles are the tibialis anterior, extensor hallucis longus, extensor digitorum longus, and the fibularis tertius. Tibialis anterior, tibialis anterior and the extensor digitorum longus are two muscles that come from the tibia, and the rest are from the fibular bone. Okay, so we are going to look at that in a moment. So this is the tibialis anterior muscle, very, very, very anterior on the leg. Okay, everybody can feel this on their own leg. Afterwards is the tibia bone. So runs from the proximal part of the tibia, just the medial condyle, around that medial condyle. Sorry, that's a medial condyle, lateral condyle of tibia, and to run downwards to the medial cuneiform. All right, so it moves that way. And we also have, so they are all dorsiflexors, and they all extend the toe. So they are all dorsiflexors. They dorsiflex the ankle and they extend the toes. All right, so they're supplied by the anterior tibial artery. That's the blood supply, anterior tibial artery, and they are innervated by the deep peroneal nerve, also what known as the deep fibular nerve. Okay, so this is showing us this in the table format. Okay, so you can see that the anterior compartment, we have the anterior, the tibialis anterior, which lateral condyle of the on the superior half of the lateral surface of the tibia. All right, and the interosseous membrane, and it will insert on the medial and inferior surfaces of the medial cuneiform and base of the first metatarsal. Okay, then the next bone the next muscle that arises from there is the extensor digitorum. All right, extensor digitorum longus. Extensor digitorum longus. It's important to note that we have the tibialis anterior, and we also have the two extensor muscles, extensor digitorum longus and the extensor hallucis longus. Hallucis already tells us it's going to the hallux, which is the big toe. The digitorum is going to the lateral four toes. Lateral four toes. So while the hallucis works on the big toes, the digitorum works on but they are all longus because they are all, where the brevices. Most likely the brevices would be in the foot. Okay, so we'll look at the brevices in the foot. But let's continue and look at, so we can go into more on the lateral compartment of the foot that are just two. So let's move on and see what this is. So these are the more on the lateral compartment of the foot. They are lateral to the fibular bone, okay, and they are in between the anterior and the posterior intermuscular septum. They are just two muscles, fibularis longus and fibularis brevis. So I call them FLFB. Okay, fibularis longus, fibularis brevis, and so they are all inverters. So they are inverters of the foot, and they are innervated by the superficial peroneal nerve. So while the deep peroneal nerve innervates muscles on the anterior compartment, the superficial peroneal nerve will innervate muscles on the lateral compartment. And the blood supply is from the muscular branches of the peroneal artery. And peroneal artery is a branch of the posterior. Peroneal artery is a branch of the posterior tibial artery. All right. So let's continue. So this is a diagram showing you the different attachments, origins, and insertion of the nerves. Okay, so sort of the muscles, and this is the muscles are the extensor digitorum longus, and fibularis brevis, and fibularis tertius. Also, we have the fibularis longus inserted here. So let's move on. So this is the posterior compartment muscles, and they are located in posterior to the interosseous membrane, just the way I said it before. So they are divided into deep and superficial muscles, and they are divided by the interosseous membrane and the posterior intermuscular septum. Not the transverse intermuscular septum. So between the interosseous membrane and transverse intermuscular septum, we have the deep muscles. Now, posterior to this transverse intermuscular septum are the superficial muscles of the leg. So let's move on. All right. So the deep muscles will comprise the tibialis posterior, flexor hallucis longus, flexor deuterium longus, and the popliteus. These are deep muscles of the posterior compartment of the leg. But the superficial muscles will include the soleus, the gastrocnemius, and the plantaris. The soleus and the gastrocnemius will form the calf muscles. Soleus and gastrocnemius will form the calf muscles. So let's look at. I also like us to take note of the similarities between the deep muscles of the posterior compartment and the muscle on the anterior compartment of the leg. Where we had in the muscle of the anterior compartment, we had tibialis anterior. Here we are having tibialis posterior. Where we had extensor hallucis longus, here we are having flexor hallucis longus. Where we had extensor deuterium longus, here we are having flexor deuterium longus. Where we had fibularis tertius, we are having popliteus. So let's move on. They are innervated by the tibial nerve, and also the blood supply is from the posterior tibial artery. Okay, and it's important to know they are all plantar flexors. These muscles are all plantar flexors. So this is a diagram showing you the different muscles. Okay, so this compartment also comprises the sural nerve, the medial cutaneous nerve of calf, and short saphenous vein. Okay, which would eventually empty into the popliteal vein, and so we also have the perineal communicating branch of the common perineal nerve. So this is a tabular format showing you the different muscles and their origin and insertion. It's good you look at them carefully. So let's move on because of time. The blood supply to the leg is from the popliteal artery, which divides into the posterior tibial artery and the anterior tibial artery. So the posterior tibial artery is this is the posterior tibial artery, which is like a direct continuation of the popliteal artery. All right. While the we have the anterior tibial artery, which divides immediately bifurcates and forms the circumflex femoral artery. Forms the circumflex fibular artery, which would circumflex around the neck of the fibula. So again, that makes it susceptible to injury because it is very superficial. So it circumflexes around there with the common fibular nerve too. The common fibular nerve. So any injury to the neck of the fibula would damage the nerve and this blood vessel. And that could lead to a lot of hemorrhage. Okay, so we'd also have the nutrient artery. We have the nutrient artery to tibia, all right, and nutrient artery to fibula as branches of the posterior tibial artery. So fibula artery from the tibial artery, posterior tibial artery. Nutrient artery to the tibia and nutrient artery to the fibula. We also have the anterior tibial artery giving up the circumflex fibula, which we just talked about around the neck of the fibula. So let's see, this is a diagram showing you cutaneous innervation. So that's the sural nerve supplying the posterior compartment of the leg, all right, on the lateral side. And this distribution explains it all. Okay, so clinical correlates. Let's look at this quickly. When the common fibular nerve is damaged, what do we do? What happens? When the common fibular nerve is damaged, all the muscles on the anterior compartments and lateral compartment of the thigh are gone. So we have the evertus gone, and we also have the dorsiflexus gone. So there will be unopposed pull by the muscles of the posterior compartment, and that will cause a foot drop because the muscle of the posterior compartment will insert on the plantar surface of the foot, and that will pull the muscles, the foot downwards, and there's no opposition to that because the muscle and the anterior compartments are all gone, and those of the lateral compartments are also gone. So we have what we call foot drop. Okay, so when there is foot drop, you notice that there is a waggling gait. Why? Because the individual is trying to bend, so he flexes the hip and tries to a bit flex the knee a bit, trying to make sure that the foot does not drag on the floor. So in a bit to do this, you will flex the hip a bit, and you see bend, tilt towards one direction, trying to use the hip to and the knee to take up the foot from the floor, clear the foot from the floor. And he performs different kinds of gaits, the waddling gait, the swing out gait, the high stepping, or what they call steppers gait. All these things occur when there's foot drop. Okay, so these diagrams here try to show you the causes of the nerves, the tibial and the common fibular nerve. All right. Again, here quickly, you will get to understand why I'm bringing this up here, but for the sake of explanation, let's just look at this. You can see that this is the posterior view, and this shows us the sciatic nerve. Okay, so that's the common fibular nerve diverting laterally, and this is the tibial nerve going downwards. All right, so this tibial nerve will supply most of the also on the posterior compartment. All right, so you see it supplies gastrocnemius publicus. It also goes to supply the flexor digitorum longus. Then it goes downwards, okay, into the foot. This is where I was going to, where it supplies all the muscles of the foot. All right, it supplies all the muscles of the foot except, and I'm going to give that exception very soon. So let's run to the anterior compartment where you see the exception. So in the anterior compartment, you see the exception of the muscle, which it does not supply. This is extensor digitorum brevis. That's the exception of the muscles of the foot. That means muscles that are in the foot that it's not supplied by the tibial nerve. So you see that? All right, the extensor digitorum brevis, while the rest are supplied by the tibial nerve. All right, then we also have the common fibular nerve supplying the, of course, we have talked about the lateral compartment muscles and also the anterior compartment muscles. So the deep fibular nerve also could be trapped because of its location in the foot. All right, it could be trapped by the extensor retinaculum, right, the inferior extensor retinaculum, and the extensor digitorum brevis. Okay, that position where it is, when an individual is on a tight shoe, okay, it could compress the nerve, and that could cause a lot of excruciating pain for the time being, okay, which would eventually relax. Okay, but this occurs with tight shoes, very tight shoes, like as seen in sky hikers or those who do mountaineering and all that with tight shoes. So it leads to what they call sky boot syndrome. Okay, so that's the flexor, that's the extensor retinaculum, the inferior extensor retinaculum, and then here you have this muscle here, okay, which is the extensor hallucis brevis, okay, and so it could compress the fibular nerve, deep fibular nerve, just around here, and that could lead to what they call the sky boot syndrome. Okay, so the pains would radiate to the first two. All right, the web between the first two and the second two. So that's what it's readily seen during the sky boot syndrome. And we also have superficial fibular nerve entrapment. Okay, so where here you find ankle sprains, okay, due to the fibular superficial fibular nerve entrapment, it gets compressed or trapped, okay, and this would lead to chronic ankle pains, all right, and the lateral side of the leg, okay, because this is a superficial, this nerve arises just after the common fibular nerve has circumflexed around the neck of the fibula, all right? So if there's an entrapment, remember this nerve is the one that supplies all the muscles in the lateral compartment. Of course, the weak eversion of the foot, okay? And there will numbness and paresthesia, and this may lead to tickling or tingling sensations. Okay, so let's look at gastrocnemius strain, and this occurs a lot in those who are older than 40 years old, who involve themselves in sports without really warming up their muscles. So they involve themselves in a sprints, a spontaneous sprints, all right, without really warming up their muscles and all that. That could lead to a tear in the belly of the gastrocnemius. Okay, all right. Again, that kind of strains you could also be seen in the calcaneal tendon, where tendon is also torn. But I'll look at that soon. So it is caused by overstretching of these muscles, and that leads to, and that again, extended dorsiflexion of the ankle could also lead to a tear of this muscle. All right. So now there could also be an accessory soleus. All right. So you can see the soleus belly and accessory soleus belly. Look at where it is. Soleus that we always know to be very prominent, proximal to the tibia, proximal part of the tibia. But here is an accessory soleus. So this could lead to a lot of edema or pain around this region, because of course it's going to compress the tibial nerve as it runs downwards. Okay, so again, it leads to pain, and it will also lead to edema, swelling around that region during prolonged exercise. This is present in about 3% of people. We also have what they call the fibula in the gastrocnemius. So fibula is a sesamoid bone that is found in the lateral head of the gastrocnemius. So it's called fibula. All right, in the lateral head of the gastrocnemius, sometimes the sesamoid bone is just found there, and that could lead to sometimes pain. Okay, in these individuals. This could be found during radiographs. Okay, on the lateral head of the gastrocnemius. That's very important, and it's found in about 3 to 5% of individuals. So we also have calcaneal bursitis, where the bursa of the calcaneus tendon is inflamed. Again, I said this occurs in sportsmen who just jump up into sports without toning their muscles. And frequent movement of that muscle, especially during basketball, tennis, and long distance, could cause inflammation of that bursa, and that's so that we call that calcaneal bursitis. Then again, we could have posterior. We could take the posterior tibial pulse in the ankle, or at the medial side of the ankle, where the posterior tibial artery passes. Okay, so to do this, we would have to invert the foot, so that the flexor retinaculum is a bit relaxed, so that you can have easy access to the artery and take the pulse. All right, so that's a very good place to take pulse, especially in very fat people and all that. Okay, so let's look at so that's still on the posterior tibial pulse. It's important to do this on both foot, so that you can take a balance of the pulse, all right, to get to know whether the pulse is running symmetrically. Okay, so it's absent in about 15% of normal young men, and but again, it's also not seen or absent in people, elderly people from the ages of 60 years and above. So, the plantaris is another very good muscle for grafting. So during plastic surgery or corrective surgery, Plantaris tendon could also be taken because of its tensility, right? The tensile strength of this muscle, right, could be used in reconstruction of anterior cruciate ligaments, which is the ligament in the knee joints. Also, it could also be used to replace some of the flexor muscles if they are lost during maybe an accident or something, or fire incidents. They could use the Plantaris tendon to replace them. So the tendon also could be used for atrioventricular valve repairs. We have the tendon, the tibial nerve. Injury to this tibial nerve will lead to complete loss of plantar flexion. All right, plantar flexion, toe flexion to the toe is lost completely, and flexion to the foot is also lost. All right, so containment of the spreading of pulse, of infection, could be could be contained by these compartments of the legs. All right, so the different compartments could keep the spread of force. All right, so within that compartment, they don't allow them move from one compartment to the other. That's one very important clinical correlate of this compartment. So force would rather spread downwards in the posterior or anterior compartment of the tire, but in the lateral compartment, it could spread upwards. Okay, so we've come to the end of the lecture, and I really want to say thank you so much for listening. All right, so please, if you've enjoyed today's lecture, I advise you subscribe to the masteranatomy.info so that you could access all the quizzes on this lecture, all the quizzes, and also look at other lectures too. You don't need to subscribe anymore. One subscription is for all. All right, and you access all the quizzes too on the other lectures. Thank you so much. Do have a great time. Cheers. All right.